Welcome. Myself, Dr. Rujuta Fuke, and I welcome you all to this web series on colposcopic update. The Nagpur Obstetrics and Gynecological Society, in association with Foxy Gynecological Oncology Committee, has started this very novel, good idea of having this web series or webinars on colposcopy updates. And we have a very eminent speaker, Dr. Priya Ganeshkumar, with us for the same. Until now, we have completed first episode of these four out of these four episodes of colposcopic update, and this first episode was on basics of colposcopy, and it was a super duper hit. We had a record break of more than 100 logins for this, and we had to emergency update the Zoom to accommodate the participants. And after this highly successful first episode, we are looking forward to the second episode, which is on the scoring system of this colposcopy. And to start this session, I invite our eminent chairpersons for today's session. And we have with us Dr. Priya Ganeshkumar ma'am, and she will be chairing this session. And we have Dr. Namrata Rathod ma'am. Dr. Namrata Rathod ma'am is busy in one section, and she will be joining us late. So I request Dr. Priya Ganeshkumar madam to start the session. And Dr. Priya Ganeshkumar ma'am, she's a consultant obstetrics and gynecology, consultant in obstetrics and gynecology at Tone Maternity and Laparoscopic Hospital, and she was lecturer in obstetrics and of Indian College of Maternal and Child.
Hello, good evening. Rujita, is your
special interest? So I welcome you, ma'am. Hello.
Hello.
Am I
audible? Yeah, you are intermittently audible.
Okay. Okay. So sorry for that.
Rujita, can I have a CV of madam?
Yeah. Next slide, please.
Yeah. Got it. So hello, everybody, and welcome to the second episode of colposcopy about the scoring system. Today, we are going to learn from none other than Dr. Priya Ganeshkumar. As we already witnessed last Monday, she is a prolific speaker and a passionate teacher. So Dr. Ganeshkumar is a medical director at Sai Nivas Healthcare, which is a chain of preventive oncology centers pan-India, and she is chairperson Gynecologic Oncology Committee 21-24. Madam is recognized by WHO, IARC, IFCPC for colposcopy and cytology course training for India. She is a Foxy colposcopy course conductor as well, and she is an official master trainer for cancer prevention under NCD Ayushman Bharat project, Government of India, for the state government of MP. She is a PhD guide at Bharati Vidyapeeth University, Pune. She has many publications and books to her credit. She is the author of Colposcopy in Practical Gynecology and author of Atlas of Colposcopy. She is an official reviewer for Jogi Foxy Journal for the oncology section. She is an executive member in the Foxy GCPR for the cervical cancer prevention and screening. She has numerous publications and articles in Foxy Focus and in various international journals. She has been recognized for her mammoth work in colposcopy for preventing in the preventive oncology section by many awards. She is recipient of the Economic Times Inspiring Doctor Award 2018 at Delhi, IMA Excellence Award 2019, Wonder Foxian Award 2019, and the Top CMO 2021 as Industry Leader in Healthcare by CEO Insights. She has held many key positions at various posts. She has been member of the core team invited by the President of Malawi, East Africa for MMR Reduction Project Malawi 2015. And she is at present Secretary General TOGS, Oncology Committee Chairperson of TOGS. On top of that, she is a great researcher and a scientist with many researchers. She has spearheaded many researchers in the field of colposcopy and the tumor markers. So, Madam, we are looking very much forward to listening to you and learning about the scoring system with colposcope, which you have said is the stethoscope for the gynecologist. Over to you, ma'am.
Thank you, Dr. Pragnya. Thank you, NOGS Society and ACO Society. It's always a privilege to be with you all. And so I had a lot of requests after your program from many people that they missed out and they wanted the recording. And I also then requested Varsha that if you can give the recording.
Ma'am, the recording is available. Actually, it's available on our site, NOGS site, but I'll send it to you personally so that you can forward it.
Yeah, so I then told them they can join today and so that we can have a little brief up of what we did and then we pull our new session.
Okay.
And also I gave you, Varsha, that article, if you can forward it to your society people. So that's relevant for this. You have?
Ma'am, I already have sent it. I have posted it to each and every member of our society.
That's fantastic because that's relevant to this talk of today.
Yeah.
So we start and I take you from here. Okay. So this is visible? Yeah. All right. So dear friends, again, we are back today with understanding about the CIN part. And we did understand CIN last time. But just before we start the new session, we have to do a little brief up of what we had learned. So when we talk about a cervix, and this is how normally we also say for our patients also, that when we talk about the cervix, why do we have to do a colposcopy? What is the relevance of a colposcopy? Is it not okay that if I have a hysteroscope, I can just do it and see what it is? And all that structured thing. So when we talk to a patient, we have to explain it in this way. And this is what I do and I make them understand. So of course, all my centers we have this type of understanding that we tell our patients that, look, out over here in this quarter, it's happening as a normal cervix. But here, then they say, yes, we can see certain tumors and it's cancer. Then we say, what do you see in this two portion? And then they say that, is it looking okay? So we say that if we do not do anything, it might look like a normal cervix. But then only we apply certain things and then the hidden part comes out. And so that's our precancerous condition. And when we are able to tackle this precancerous condition, we are able to identify them by the signs of colposcopy. Then definitely by treatment, we will not want the patient to go to cancer. So this is the structured methodology of explaining to the patient also, why should you do a colposcopy? Another thing is whenever we are doing a colposcopy, we never report it as SIN 1, 2, or 3, unless and until we do have evidence with a histopathology. So in a colposcopy, whenever we have a lesion, and that's what today we are going to see, that when we have a lesion in front of us, how do we interpret it? How do we report it? And along with the reporting, how do we SWEDE it? And what is the relevance of SWEDing? That's also something, or when scoring. So that's also we are going to see today in this episode. So we have over here SIN 1, that means a dysplastic cell covering 1/3. SIN 2, dysplastic cell covering 2/3. And you can see over here the arborization. It's indicated by understanding the fact that you require neovascularization and arborization of the blood vessels to actually feed for the dividing cells. And we have seen the histopath last time that the stromal papillae, this is your stromal papillae with the invagination. Again, this is the stromal papillae. And you can see over here neovascularization. And this is a whole structured thing where you see dysplastic or dyskaryotic cells. There are so much of this high NC ratio cells, aberrant type of cell structures like tadpole type of cells, hyperchromasia, and anesiocytosis. All these things which we actually read on our histopath, we are supposed to even understand those terms in a better fashion to understand these things. Now, so here we have SIN 3 where the whole of the structure is dysplastic, the whole of this thickness. Here we have where we have this 2/3, and till where there was a 2/3, you can also see these are your perinucleocytic halo cells, and which is called as coilocyte. So now a coilocyte is, it's a pathognomic feature of HPV. We all know about it. And whenever we do have this type of structure, and if you're lucky enough to actually observe your histopath section, you can ask your, you can have a microscope with you and you can actually increase your interest in understanding histopath. You would be able to see this type of pictures. And that's where you can see over here, these are the basics of understanding the punctation marks. So when we know about this, that HPV being the lead cause and you get the cytological abnormalities and then persistent infection with HPV causing precancerous condition, definitely we would want to detect it at the earliest. We would want to treat it so that we don't want our patients to go into cancer. For this, we last time had done these terminologies. So they are very simple terminologies like what is a squamous epithelium, pink in color with stromal papillae, the relevance of a columnar epithelium, why looking, say yesterday I had a live section at Bhopal and we had wonderful cases. In fact, that type of workshops are the need of the hour when people do understand what is island of columnar epithelium. How do I understand that from a mosaic? See, yesterday, like when there was a lot of islands and patches, the people were saying like this, madam is looking like a mosaic pattern. So we, dear friends, we all have been undergoing this type of, webinar series and this type of lectures. And many of you all have attended my webinar series n number of times, but only and only when you start actually doing it. You start seeing the cases, and that's where you can put your clinical this thing into it, acumen into it. Okay, where do I call it as an island of columnar epithelium? So there, when I was teaching them yesterday at Bhopal, I told them, look at the structure of the epithelium and try to understand that this epithelium, why is it called as an island of columnar epithelium? Because of the granular reddish structure. So that's where you understand a columnar epithelium in a better fashion. Then, of course, SCJ is something which we all, as a colposcopist, even why a colposcopist, even when you are doing a screening, this is the basic thing. If you cannot understand a SCJ, there's no point or relevance in doing a VIA screening either. So SCJ comes, it's a terminology where you have a junction between a squamous and columnar epithelium. And we yesterday, or last Monday, we saw that we have 3 types of transformation zone. That's transformation zone 1, 2, and 3. So what is transformation zone 1? When all the columnar epithelium is evidently seen on the cervix, it's like over here. So we have columnar epithelium, which is looking granular in structure. Squamous epithelium, which is looking pink and smooth in structure. Now, out over here, whenever we talk about the squamous epithelium, definitely we talk about the original squamous, which is more pinkish in color, and a whitish structure, a little bit of whitish pink. It's a metaplastic squamous epithelium. So this is what you have to really garner on doing colposcopy n number of times. If you start doing it, the more you practice, you're going to really understand the tissue much better. And then suddenly you get certain things like, whitish looking patch on the columnar epithelium. You should know it very correctly that this appears like a cloudy, it's not dense white, right? It's just a cloudy appearance and it's merging with the rest of the tissues. And once you do a colposcopy, you wait for a minute. Once you put an acetic acid, you wait for 1 complete minute, and that is also going to pass away. So that's something called as metaplasia. And you have the transformation zone 2, where your new SCJ is on the os with a little bit of a patch seen. The relevance for this is whenever you're treating a patient. And yesterday we were asking a lot of questions. It was a very interactive sessions. Somebody, when I asked them a question that, will you do an ablative technique? Till when can you do an ablative technique for treating the lesions? And the answer was only TZ1. Now understand, dear friends, WHO has come up with a certain fantastic understanding. What is that understanding? That you might not be adept with a LETS. No, not everyone are adept with LETS, with excisional procedure. Then where can I limit myself? So the other thing is, even if it is the TZ2, I'm sorry over the voice. I'm continuously these days talking. So it's like my voice is really gone for a drone. So anyway, so bear with this dirty voice. So we have over here, this is the SCJ. If suppose I have a lesion here, will I treat it with an ablative method? If ever my probe, cryo probe, is having that nipple and I am able to go into it, and if I'm able to ablate the whole of SCJ, then I would be in a position to do a ablative method for a transformation zone 2. So that's the relevance of understanding our transformation zone. And then you also have over here transformation zone 3, where your SCJ is absolutely not visible. It's withdrawn inside, and you have this type of frond-like, finger-like structures which are cloudy, and that's how you understand a metaplasia. A metaplasia is a cloudy white, pale white, mixing with the rest of the tissues, appearing and disappearing fast. And last time we very vividly had seen, and we had really plunged deep into understanding blood vessel patterns. And again, just for the sake of a revision, I'm trying to tell you all that these are the reticular patterns, which are very, very common ones. You would find them a lot in an atrophic or a perimenopausal age group, and you will also be finding many punctation marks. Last time, we also understood what was punctation and what is crypt opening. So whenever you're doing a colposcopy, the first thing what you will do is you will try to identify the distal crypt openings. Now I'm marking the distal crypt opening for you all. All right, and then that gives me an understanding that during her pubertal time, early reproductive time, her columnar epithelium had flown till here. And then this becomes your original squamous epithelium. Look at the color combination. This is an original squamous, and these are all then later on turned metaplastic. So metaplasia is a physiological terminology. How does a metaplasia look? It's looking more pinkish white in color. And it's like here, it's TZ3 because it's a menopausal age group. And don't worry about this type of, petechial hemorrhages, which is very common, atrophic epithelium. Another thing which you have to understand is whenever you're doing a colposcopy, I'm going back to this atrophic epithelium. I have been warning many of my candidates who have joined me for the hands-on courses also. More than 1,000 or so would have been trained. What I tell them is avoid doing a colposcopy directly on a menopausal age group. Why? Because you would be seeing an atrophic epithelium which has basal parabasal layers, which has high NC ratio. So whenever you're putting an acetic acid, it's all going to turn white. You would never know which whiteness to call as an actual lesion whiteness and which one to say as a normal tissue for that matter. Leave apart metaplasia, just a normal tissue. So that's the reason you have to do more on a reproductive, and that's how exactly when as a WHO guide for fellows in the country, I normally try to give them the initial reproductive ages, colposcopy. And slowly, subsequently, we take them through doing the menopausal age also. This is what we had seen for understanding mosaics and punctation. We had done this, and mosaics and punctation are certain things which you will have to understand well. And the steps I had told was first, after the consent, taking the right, all that paraphernalia attached to the colposcopy is, number one is understand this is a very sensitive issue. Whenever you have to take a patient onto the couch, it's very important, that you talk empathetically to her and make her understand, because these days everyone are a Google patient and they have read enough to understand and scare themselves out that colposcopy is done to understand cancer. So they attach that fear factor to a colposcopy, and whenever there is a fear factor attached to the colposcopy, they aren't at all, at ease. So when they're not at ease, they try to squeeze their pelvis, and we all have undergone this type of patients that the cuscus just is thrown out. You would have applied acetic acid, and at that time you haven't even told that it's going to burn. It's going to little bit cause a discomfort to her, not burn, in fact. So a little bit of tinging. So my request to you all would be, kindly get your own colposcopy done. I do this for all my candidates who come to training program. I have kept this for 1 decade of my practice. I'm now teaching 1.5 decades, but since this 1 decade, what I have understood is, unless and until the candidates gets their colposcopy done, they really do not understand that it's such a simple procedure. We think that, many a times I have seen in my Delhi, where I practice in Delhi also, I have a clinic out there. I have seen the patients are so fussy because why? They would have heard from their healthcare providers, whoever it may be, too much of pampering and too much of, because the doctors themselves say that, oh, agar dukta hai to fir hum anesthesia ke under karte hain. Oh, agar ye ho raha hai to biopsy. So like out of question sort of thing. In UP, because I have 30 centers, you all know that I've been traveling across the whole country, and I know the nuances of practice in different parts of the country. So I'm just sharing one nuances to you, because you might get a patient from UP and they might tell you that, the understanding out in UP is that if I do a biopsy, if I take a biopsy, the cancer is going to spread. So there are various various thought process going on around colposcopy, and so many things are done as a mismatch sort. So I want you all to get this thing very clear onto your head, that colposcopy actually doesn't have any discomfort. The discomfort is when you're applying a cuscus. You ask your patient, they would say, yes, that was a little bit paining. Why? Understanding the fact that when you are applying a cuscus, you are holding it in a pincer fashion, and you are charged up to do a colposcope, and you have put the cuscus so hard that you have pushed that cervix inside. Yesterday also, when I was in fact I made somebody do, and I was trying to teach them on the bigger screen. I told the lady to the doctor who was sitting behind the colposcope, I told her to just pull the cuscus out a little bit and see the TZ1. It was looking artificial TZ1. It became TZ2. Why? Because the cervix had closed. So the art of colposcopy lies in fact, putting the cuscus in the proper fashion. Centralizing the cervix has to look to you. And then you will start, because these procedures are very simple. It's nothing of big rocket science in the procedure. You're cleaning it with normal saline. You're looking at the distal crypt opening. You're understanding the green filter. You're putting all the green filters and trying to interpret. And then you're putting the white base, and you're starting with your 5% acetic acid. All that thing said and done, the actual crux remains in how do you insert, what type of cuscus do you take. Long blade ones are always beneficial. I always take a disposable cuscus. The plastic ones, of course, I do not dispose it in a foreign country. We are not that rich people. We definitely sterilize it in a better fashion. 2 or 3 patients, I might use it after proper sterilization. But then I have those long blade ones. So I do not have to push the cervix. I think you all are getting what I'm trying to tell you all, because these are very, very important things before even you jump into a colposcopy. Nowadays, each and every doctor is having a colposcope. The sad part is, you ask them how many of you all are doing it. They would say, no, we aren't doing it. And I get requests from n number of people day in and day out that, madam, we brought the colposcope. Can you do a resale for us? Never do that. Understand colposcopy in a better fashion. That's the basic thing, because it's the easiest thing which anyone can do. And then after application of acetic acid, remove that excess acetic acid out. And then only apply Leukols. Because if you do not do that, these are the small nuances I'm telling you. If you do not do that, your Leukols is going to get diluted. And what's the big point if your Leukols has got diluted and you're trying to do an interpretation? So all that small hints I'm trying to give you all so that you understand colposcopy in a better fashion. So these are your distal crypt openings. Before that is, you have to understand that, distal to it is the original squamous, and proximal to this is your metaplastic epithelium. Now, I'm not in a big hurry to talk about SCJ, new SCJ. I have understood the old SCJ because of the distal crypt opening, and the transformation zone I will be talking after doing an acetic acid application. I told you all about the blood vessel patterns and the relevance of blood vessel pattern. This was for healing pattern. This is for Nabothian. These are, you will see plenty in a menopausal age group. This you would see it in a metaplastic epithelium and original squamous. So out over here, we do have brought for you certain pictures I brought for you so that if you are able to see that, you would appreciate it much better. And then you have this abnormal blood vessel pattern. Whenever you see and see, like yesterday in one of the case, we had an abnormal corkscrew type of pattern at 11 o'clock position. But whenever, and I mean, they were all so happy. The 150 candidates who were sitting and watching, they were all very happy. Oh, we have found a abnormal blood vessel pattern. I said, don't become so excited. You have to go ahead to do acetic acid. And in the acetic acid, only if you have an acetone white area and a Leukols, not taken up area, these are the places along with the blood vessel abnormality, then you will have a relevance for it. Otherwise, many a times because of chronic cervicitis also, you would see abnormal blood vessels, a sort of dilated blood vessels. It's not abnormal. It is a normal regular vessel patterns, but little dilated. So give importance to abnormal blood vessel patterns only if you have it on the acetone white area. So that's the take-home message from this. And I have shown you over here broken mosaic pattern. What is the relevance of a broken mosaic pattern? Now that gives you a hint about microinvasive sealing. So even without even doing acetic acid, you have to keep this all in your mind. And that's the basics of why you require a colposcope. Why can't I just do a patient, understand a patient by doing a VIA, and VIA, I can take a biopsy and do it with it. But okay, that's a way of understanding screen and treat programs. But a VIA and all that, even that again is so tricky. So many yesterday's VIA, we all were, there was one case where VIA was absolutely, looking positive, and even the Leukols was not taken up in that same area. And when we had a polling of from the audience, almost 80% told me that, madam, this looks like a lesion. And I said, no, as an expert comment, I would say this is just a metaplasia, not a lesion. And I wouldn't go ahead doing a biopsy because I feel it's normal. And then because there was a little bit of imbalance between an 80% and me being with 20%. So we did a visual check. We had a wonderful tool yesterday with us. We had the EVA screening device, and that also couples up to be a colposcope as well. So we put the AI check, and then it was normal. So understand, so that's what I keep on telling, that colposcopy can be understood the moment you do a lot of colposcopy. You sit with their tissue and understand the tissue, you will then see a vast difference. Your understanding of the cervix and the tissue will become completely different. So we have understood that acetic acid preparation should be a fresh preparation for 24 hours. And you have 0.5 ml of glacial acetic acid to 9.5 ml of distilled water to make it 10 ml. If you want to have it 20 ml is 1 and 19. And then you have to understand as a colposcopist, when to call it as a metaplasia and how does a metaplasia look. A metaplasia is thin, shiny, translucent. So this is the googly thing, which can actually evade any good colposcopist in making them understand that, oh, this might be a lesion. So there is a understanding how to understand a metaplasia vis-a-vis to a low-grade lesion. A high-grade lesion definitely doesn't require your big expertise, because the moment you're applying an acetic acid for 1 minute, it's all looking white. So it's appearing thick and dense white, it's raised and all that. So where is your understanding for understanding a metaplasia from a lesion? So that's where your expertise lies, and we will come to that shortly. So when you apply an acetic acid, you are going to look for a new SCJ, you're going to look for metaplasia. Many a times columnar epithelium is having a cover with a metaplasia that looks white. Satellite lesion, congenital TZs and all. Okay, so you have it over here, like this is your metaplasia. What is it? How do they understand? This is thin, shiny, translucent. See this with a feathery margin, and which is blended, I can say, with the rest of the tissue. Now, for a lesion, a lesion understanding is whenever you are having a low-grade lesion, it actually starts manifesting a little late. And that's the beauty of that 1 minute magical moment. I always call it a magical 1 minute, because you would see that the lesions are slowly starting to manifest. What is that? All that recording stop. Okay, fine. So when you try to understand a low-grade lesion will beautifully start developing afterwards. But a metaplasia would look white immediately, and it would disappear also. The moment the low-grade lesions are appearing, your metaplasia would have already stopped, Now everything would have faded. So that's an understanding of metaplasia from a low-grade lesion. Another thing is a low-grade lesion will also have a clear-cut margin. You have to understand this fact very well, that there will be a clear-cut margin. There will be it will arise from SCJ. It's not that it arises anywhere. Now, a satellite lesion also arises, but it is not arising from SCJ. A satellite lesion is because of a low-grade HPV. So, condyloma, flat condyloma, what is the relevance? Why should I do a biopsy for that? So you need not do a biopsy for all the whiteness which you are seeing, unless and until you are still in your earlier phase of not understanding it well. Then it's okay. You do as much of a biopsies to understand. See, I have learned and all in a very hard way. Nobody was there to really put an emphasis and teach colposcopy the way it has to be taught today, like what I'm trying to teach and trying to get this colposcopy science pan-India and even globally. So for me, I have learned in a hard way. Every time I used to take a biopsy, correlate with my findings, and then go ahead and learn by writing books and publishing books and all that, doing a lot of meta-analysis study. But we can, over here, once we have understood it, we can actually cut it short and understand that no need to do a satellite lesion biopsy. Now, why am I saying that low-grade lesion arises from SCJ? Why am I always emphasizing that fact? It is because HPV is an epitheliotropic virus. It requires dividing cells to proliferate, to keep itself alive. So where are these epitheliotropic viruses? Where are these dividing cells? The dividing cells are the metaplastic cells near the new SCJ. So only whenever there is a HPV infection, then the dysplastic cells arises from new SCJ. So that's your understanding. So a low-grade lesion, as I told you again, I'm again reiterating the same fact. A low-grade lesion will arise. It will be dense. It won't be dense. It will be thin. It might not be dense, opaque. It might be thin, but definitely it is opaque. It is not translucent. Now that's the understanding of between a lesion to a metaplasia. Okay. It will have a feathery margin, but a clear-cut margin. Then again, one more thing of understanding is it might not have any abnormal blood vessel pattern. It might just be having a little bit of fine punctation mosaic, doesn't matter at all. But a high-grade lesion will have everything, you know, dense opaque, dense chalky white, elevated, oyster white, and all that stuff. And it will just start appearing the moment it appears, you know, it starts manifesting and then stays for a longer time. So you do have over here LCIL, HCIL invasive CA, condylomatous lesions. And then this is what we saw last time. And then we come to the last step is villi, that's Lugol's. Then we have understood the fact that stratification is a need to have mahogany brown. What is the stratification? What is the stratified squamous? Stratified squamous means the upper layer is having glycogen and hence it is a stratified squamous epithelium. So having a glycogen in the cytoplasm appears mahogany brown on applying all the Lugols. Now, which are the conditions which do not have the superficial layer? So metaplasia, immature one will not have. Menopausal age group definitely will not have. Might be an atrophic epithelium. And also trichomonial infections where you can see those ulcerative areas or strawberry patches where there are superficial excoriation of the tissues. And those areas also will not have. And then, of course, pathological villi positives. That means what? That the CIN lesions are so this thing dividing that they are only basal, parabasal. That's the reason, dear friends, if you would have put your emphasis into understanding PAP test in a better fashion, I told you if you're really keen interest in the subject, as I do have for this subject, I always try to look into my own PAP slides and try to understand those cells. And that's how I have actually learned colposcopy in a better fashion, by understanding cells well. So you would see that CIN cells, like low-grade lesions, will have only till parabasal cells or intermediate, because they're dividing. They haven't gone till your superficial layers. So so that is the reason why, and in the high-grade lesion, you will see all basaloid type of cells, parabasaloid type of cells. You will not see them as a superficial, that type of pattern wouldn't have come, because it is a highly dividing cells, and hence you are not seeing, they are not taken up. Lugol's staining is not there. Plus, there is a mustard staining or saffron staining. And that's the reason when you are applying an acetic acid, the Lugol, the columnar epithelium, since it's a single layer epithelium, that is just getting painted. You might have a metaplasia on it. So that also will turn, little bit of discoloration might be there, but that all will come back to normal color. That's what we saw last week when we had done, we had gone through the video and we had understood that within few seconds or a minute, few seconds, it is all turning back to pink. But your this thing is staying back. The lesion is staying back as brown, as a unstained portion or yellow portion, or what you can call a saffron color portion and all that. So that's the basics of colposcopy. And here we do have over here villi negative. This is just a columnar epithelium and satellite lesions and all that. Okay. So then we did see that last time these cases of like, again, I come back to the same point that if I give you this, suppose if you come to me as a WHO candidate and I give you an OSCE exam, as a prelim exam, I take you and I ask you to identify the os, and I give you only this. This is how actually the exams are conducted in WHO, and they are real good exams. So see this. How do you understand os? How do you understand because everything is discolored. You see over here, this is discolored, this is discolored, this is discolored. How do I understand os and columnar epithelium? So you understand by this type of pattern. See this? Now this pattern is rough pattern. It's a grape-like pattern or a rough pattern, a velvety pattern, right? And your lesions are smooth. See this? So this is your os. This is the columnar epithelium, which is just not taken up. It's just painted, and that would come back to your pink color. And this is your trichomonial infections and a satellite lesion. Might be this is an Ebothian just being covered with a immature metaplasia. But this is definitely a lesion arising from SCJ. And again, this is a lesion arising from SCJ, and these are plenty of lesions arising from SCJ. And out over here, this is a satellite lesion. So understanding this fact is an important thing. And we had done the procedure. So I'm not going to do the procedure today. Now I'm taking you to the next topic. So we have done the revision of basics, and we do now know that we can represent it, and we do have to represent it. People who would have seen, would have come to our training programs will have the first-hand experience of how I make you all draw this Cartier diagram. And you better make it a habit. I tell you, this is a very important tool. A very important tool is your Cartier diagram, because onto your register, because you are going to give the colored images to the patient. What is there with you as a record? You have only the Cartier diagram as a record. And you can refer to that when the patient, suppose if she's coming to you after 5 years, okay? And you have drawn the schematic diagram of the SCJ, the similar pattern of what you would have seen on your cervix, and you have actually put it onto your paper. And you would then see that, oh, that time the SCJ was here, it was a TZ, whatever, and now it has receded thing. So and also suppose if there was a lesion, you can understand that, oh yeah, here there was a lesion last time. Now she's come for follow-up. Now there's no lesion. So another third point of importance is when you are giving a histopath to your cytopathologist for analysis, okay, for biopsy, please draw a Cartier diagram. Show him that place from where you have taken. Show that that lesion pattern, and put a cross from where you have taken the biopsy. Okay, so that's exactly how you follow this as per even BCCI. Like, abroad in the BSSCP pattern of my teaching and all is a BSSCP pattern of teaching. That's why you would see my teaching, a very different teaching and a very in-depth teaching because these are international standard of teaching, where you do have to understand everything in a more specific manner. You just can't be very casual in your reportings. No. So whenever you're putting up in your Carter diagram, it has to be the representative of what you are observing them. So it might be a new SCJ, might be a metaplasia. See what we have done for a metaplasia? It's shaded. That means we knew that this is a metaplasia. Then there are crypt openings being shown. Then out over here in this two thing, we can actually represent a mosaic, if it is a coarse mosaic, by a bigger round, and a bigger mosaic pattern, and a smaller fine for things. So all these things are very important. And now we come for understanding the reporting system. So we do have IFCPC nomenclature of reporting, and kindly adopt it for reporting. What I have seen over the whole pan-India reporting systems, because I have this centers, 30 centers, and they also then try to, they have become their own ambassadors in their own area sort of thing. And certain times we then share whatever they would have seen from other places as well, because they get references also. We have seen that many a times, because these days video colposcopy is so common. And in fact, I told you, many people have their colposcope. What they do is they take the pictures and they do not report. They just put the pictures and give it to the patient. So I'll tell you one, and these are serious problems. Believe me, dear friends, people are now becoming sensitive to it. I got one patient who is a patrakar, for his wife. He had come in from a very reputed, I think, Times of India or something. And he had taken his wife for a a colposcopic examination in a corporate hospital, and the corporate sector, no, they had taken for a screening. It was March 8th, Women's Day, so screening was going on, and then he took her there, and they did a colposcope. I do not know, because see, colposcopy and all, don't do it for screening purposes, okay? Do it for whenever there is an indication, then only you do it. Otherwise, it's not indicated first as a screening thing. So what was done was they had taken up pictures, and then they said, oh, your wife seems to have cancer. See, the words are these words. Wife seems to have a high-grade lesion or a cancer. You please take an appointment with a consultant, and we might think of removing the uterus. And then that's the way these patients, the Patrakar came to me, and then when he said, Madam, and then when he saw our reporting system, he said, why did I not get the reporting system? Why was that kept blank? And I'm going to put an RTI or a case against this hospital. That's why, dear friends, of course, I had to mellow him down and tell him, leave it. You've come to the place, why do you want to make a bawal out of it? No? So I normally try to mellow these people down, because we shouldn't be against our own brethren. No? We are all brother sisters together practicing. So try to see that, don't pass any wrong comments. Don't, on the pictures, do not pass out any comment, please. And another case, I'm trying to make you all very sensitive towards it before I take up the actual topic, because of the experience, a vast experience which I have as a colposcopist in this past so many 25, 30 years. Another patient had come to me who has become psychic, okay? She has lost her mental balance. She was working as one of the HRs in a very plush position in one of the MNCs. And she happened to go to a doctor and who did a colposcopy, and similarly was not reported, but said verbally that we think that you do have certain lesions, and you have certain cancerous, that word was used, and she was so tensed. She started going into depression. She started seeping down. Her mental balance kept on going down, and finally she started taking antidepressive medicines. Might be she would have had a tendency. I'm not saying that it's all because of the doctor's fault or our miscommunication, but whatever it is, I do urge and tell you all, please be very careful. Whenever you're doing a colposcopy, if you've taken a biopsy, just wait. Tell them that I feel it's okay. I mean, let's wait for the biopsy report. Be strict onto it. And only if you feel that you've done do not give your report immediately. There's no big thing to be in a hurry. Try to have few more diagnoses with a pap test or with an HPV. As I told you last time also, we in our 30 centers pan-India, we have a strict SOP to be followed. And that SOP is you have to do another test also. It just cannot be on a colposcopy, because colposcopy sensitivity, even with the best of the colposcopist in the world is Dr. Albert Singer from UK. He claims his colposcopy sensitivity is, his reporting sensitivity is 75%. I have done my sensitivity understanding also, and I have found that I come to the tune of, say, somewhere around 73 to 74%. And nowadays, because of the good IHC tumor markers and, understanding better, might be I would have touched that range. So understand, still we do have this much of a buffer where we cannot give a final diagnosis on a colposcopy. Why do you do a colposcopy? Just to understand, is there a lesion? Is there not a lesion? Can we take a biopsy from there? And then how do I report? So this is a understanding to your patient and finally treating the precancerous conditions, and not to make your patients scared at all, and giving them the right understanding that this all can be prevented, no need of a hysterectomy. So when we do a nomenclatures, and the need for a nomenclature is to report it. So reporting system is very important. As I time and again, I keep on telling you. First of all, you will see for adequacy, inadequacy. So your reporting system will start itself from adequate colposcopy or inadequate colposcopy. Whether you're, what do you mean by adequate, inadequate? That is whether you're able to see the cervix in a proper fashion, or is there any bleeding, scarring, or inflammation? Just a minute. I'll mute myself for a second. Yeah, sorry, I come back. So adequate, now what is inadequacy? That I am not able to see the cervix. It's obscure because of inflammation, bleeding, or scarring. Then the next point will be whether you are seeing the SCJ completely, incomplete, or partial. Okay. So then you will talk about transformation zone 1, 2, and 3. So these 3 should come as your starting. Then you will come to understanding the tissues now. So what are you seeing on the tissue? Are you seeing it? Now again, other thing, ectopy. So these have come from the Rio classification 2011, which has seen certain changes. Initially, we used to have, before this Rio 2011, we used to talk about satisfactory colposcopy, unsatisfactory colposcopy. Those terms are not in use anymore. Okay, so don't use it. The old timers, we are all very much habituated of talking those terms, satisfactory, unsatisfactory, because we couldn't see the TZ, so we would say unsatisfactory, but it's not this thing now. Now you can see the TZ, even in the TZ3, you have that long, wide endocervical speculum. Open it up, you can see the TZ SCJ inside. That's not the problem. The problem is now talking about adequacy, inadequacy. What will you do if your cervix is inadequate? You will explain to the patient that, look, I'm not able to see the cervix the way I should be able to. And hence, my colposcopic interpretation will not be in a proper fashion, because you are having bleeding, you're having a scarring tissue, you've had certain inflammations. So might be I can just give you certain F-heal or certain antibiotics, and I call you later on for doing this. So this thing, examination. So that's the thing that you have to explain to the patient. Then talking about ectopy. What is an now that term of erosion has gone up. Okay. So come out of that old terminologies. Oh, I'm seeing erosion. Many a times this erosion word is a misnomer. We cannot use those words. Our teachers were using it, so we were using it. And same way through tradition and hereditary, we are all got in batches saying erosion. So let's stop from now. Either it is an ectopy or an ectropion. Then what's a true erosion? You can ask me, madam, don't you have a true erosion? Yes, there is an erosion when there is an excoriation or an ulceration. So an ectopy and an ectropion, what's the difference between that? An ectopy is when physiologically the whole columnar epithelium has flown till whatever that the distal crypt opening. That's an ectopy, and that's because of your physiological growth of the columnar epithelium because of hormones. And what's an ectropion? That's whenever there is a lateral, delivery has occurred, lateral tear, and it's like a cervix mouth is opened up, and you are seeing artificially a lot of columnar, but it's not an artificial, of course, it's a scene, that's it. So that thing is called ectropion, and the originally a floored one is an ectopy. So you can ask me what's the clinical relevance, Priya, for that. I would say actually no clinical relevance, even if it's an ectopy and an ectropion, because the patient is going to come to us with what? With a white discharge. And sometimes even with a postcoital bleeding, if there is an ectopy or an ectropion, because it's a columnar epithelium which is now exposed, right? Then, so that's one thing. Then you have to see whether you are seeing any nebotin cyst and all that. And then what else will you try to see? So these are all the normal clinical findings, and you have an abnormal clinical findings, like if you have seen a lesion, then where did you see, which position did you see, was it what is the characteristics of the lesion? Are they thin acetone-white with a geographical border? Are they thick, dense, rapid occurring? Is there any cuffed crypt? And then did you see any fine mosaics or punctations in a low-grade lesion, or in a high-grade lesion might be, did you see any inner border sign or a ridge sign? And now they're going to add up rat sign to that as well. So coarse punctation, coarse mosaics, all these things you would be able to see if there is a lesion. And then what is a non-specific complaints? Like, no, you might see a leukoplakia. Like yesterday, somebody asked me very relevant question. And these are the very practical questions asked by the candidates. Like, madam, how do you understand a leukoplakia from a condyloma? So how do you answer this? The answer to this is leukoplakia will be a white, aceto white, creatic patch might be. It's not an aceto white. It is a white patch even before applying acetic acid. So you would see a leukoplakia white patch because of fibrosis, or maybe because of whatever, during while even doing a normal saline. Whereas a condyloma will appear only after application of acetic acid. So that's the relevant understanding between a leukoplakia, hyperkeratosis and all that. Okay, then you'll put a Lugos, and then you'll try to find where Schiller's test has been stained, unstained, and all that. Then what is the suspicion of invasion? The suspicion for invasion is, as I told you, atypical vessels, irregular breaking mosaic patterns, then fragile vessels, and necrosis, ulcerations, and all that. Then you come to miscellaneous finding: congenital TZ, stenosis, or polyps, endocervical polyps, then congenital anomalies, and all that, endometriosis. So let's go to each term and understand it in a better fashion. So here I am seeing the cervix well, adequate cervix. This is an inadequate cervix, right? In this, even if I do a colposcopy, I'm not going to understand the how to report it. Like the other day, if I get time, I would definitely like to show you a case of Orissa case, which was sent to me. I'm talking of long time back. She had come to Thane from Orissa to one gynecologist who did a biopsy because her pap had shown ascus or SIN1 or something from Orissa. So she came to her mother's place over here, the doctor to whom she had delivered or whatever. So that doctor did a biopsy, okay? And it was done so horribly that then it was charred. The report came SIN1. And now the doctor sent the patient to me and said, Priya, take care of this. So now when I put a colposcopy, and I would actually love to show you the picture if I get time today. It was all charred, okay, and completely shattered cervix. Now in this case, it's an inadequate colposcopy. I just cannot do it. I then asked her to apply certain creams like F-Heal cream and all that, and called her back after, say, 6 weeks. And then I think I could see her fantastic colposcopy. And the lesion wasn't SIN1, it was actually SIN2. And I could take a good punch, because colposcopy is done to understand where to take a biopsy from. So that's what I told that referring doctor also. Had you sent her in the first go itself with a colposcopy guided biopsy, it would have saved her 6 weeks of, sort of waiting for an inadequacy to become adequate and all that stuff. But then that was some case where you can apply certain local pessaries or something and to make it clear and smooth. But many a times, if there is scarring, like there was one lateral tear patient, and she had on her both cervix, there was a lateral tear, in fact, and there was, in one tear, there was a small SIN1, and another tear, there was a small SIN2. Even that was a very, very khatarnak case, which was after 3 gynecologists, that patient had come to me to see. So those cases, then of course, you can't do anything. You have to go ahead doing a biopsy or taking so the understanding of colposcopy really matters a lot before giving an interpretation. Then is the case where you would then ask about SCJ, where it is completely seen, partially seen, not seen. So TZ1, TZ2, TZ3. Then you go to understanding the epithelium, squamous epithelium, whether this is mature, whether this is atrophic, whether are you seeing any metaplasia, or are you seeing an ectropy? You see this? This is ectropy. This is an ectropion. Then are you seeing any nebotheal? Are you seeing any crypt openings? Or are you seeing anything like deciduous? So I was asked to write an article, I think for Foxy Focus or whatever, about pregnancy, colposcopy in pregnancy. And I had also brought some cases where, this case of mine, where this is a deciduous looking colposcopy. Now, will you do a colposcopy in a pregnant woman? So the answer to this is no. And many of the guidelines are also actually against it. Unless and until, you will be doing a PAP, you will not do an HPV for a pregnant woman. If you even ever you have to do it, first of all, you don't do it. Only if there is an opportunistic screening and she hasn't got her PAP done, or you think that the cervix is looking certain suspicious, and that's the time you will take a PAP, and then you will be doing a colposcopy if your PAP is above ascus or so, and then you will do it within the first trimester. So if ever you want to do it. But of course, you will not try to do some lead procedure or something to her, even if you find a high-grade lesion. So let me get you to this case of mine. This is a case where the colposcopy is done in a pregnant woman, and I didn't know exactly whether she was pregnant, because in my case, whoever comes to my my hospital, we do a PS and we try to see the thing, and we take a PAP and HPV, as I told you. And this she had come to me for infertility, rather secondary infertility. And when I saw the cervix, I said, no, yeah, it is looking very this thing. You come down. So I evaluated her, and for her luck, the same month, she was actually, she had become pregnant because we had not seen her next cycle, right? We did it in the intervening period, and we didn't know that the same cycle she has conceived. So in this case of this, so that's the reason I was seeing all this deciduous type. And see, out over here, I saw one lesion. This was a high-grade lesion. Since I took a biopsy, I didn't know she was pregnant. Of course, I took a biopsy, and that was showing SIN2, her high-grade lesion. And then I had called her for follow-up. And in the meantime, she said she has missed her period. And we did a UPT, it was positive. And of course, then we didn't do any treatment. We just kept her up under surveillance. And and we then followed her up. We delivered her and then called her after 4 weeks of 4 months. Now, usually you can do, colposcopy 4 months postpartum. You can do it. It's convenient. What I saw was this had actually regressed from SIN2 or SIN3 to SIN1. It was a very minor thing. Even that was also not there for that matter. Later on, even that had regressed. So what you do is in a pregnancy, this is how actually it looks, and it can, because of the hyperemic type of thing, it can look very dangerous or different, sort of thing. So now when you talk about the abnormal colposcopic finding, you'll talk about the location, the characteristics. So see over here, it is thin acetone-white areas, very thin. You might even try to ignore it. It can get ignored because it was not evidently seen. But when you're applying a Lugol's, definitely the Schiller's test is coming positive. And when you take a biopsy, it was SIN1. Now here it is very clear. See, this is an acetone-white, dense acetone-white area, which has a clear-cut margin. And that's also having a villi positive as well. Again, out over here, you can see this is again a dense acetone-white area, which has got mosaics, and it's occupying 2 quadrants, and are having a mosaic patterns. So these are the type of understanding which you will be having. Again, now non-specific. Now this is leukoplakia. Now here in this picture itself, I have 2 things. I have a condyloma and I have a leukoplakia. How do I understand this? Oh, I told you again that I'm again coming back to the same point that when you apply, when you are taking the patient in a normal saline itself, you might see this patch. Okay, but which will of course become more white when you put an acetic acid. But this condylomatous picture arises, this white thing, shockingly white. It appears only when you apply an acetic acid. So that's the difference. And then erosion. Now, when you talk about eroded, so this is actually erosion. This is eroded. And here, if you call erosion, it's okay. All right. So then you have atypical vessels and necrosis. So this is your necrotic area. Now, this story also is a very funny story. let me tell you this funny story of this so that you know what exactly is going on in
What happened?
negative for intraepithelial lesion or malignancy. See, that is normal normal practice.
Ma'am, we just missed you. Your talk was just paused for a second when you were going to talk about this patient.
Oh, okay. Now am I okay? Because no, there is an intermittent problem with my internet.
Now you're okay, but we missed that patient story, you know.
Yeah, I'm coming back to the story. So this story is like, I can see, Varsha, you're becoming highly interested. Thank you very much. Great.
I might be a candidate to come over to Thane for a training.
Yeah, I can understand. And you should. You should. It's a wonderful world of colposcopy. All right. So this case is the 37-year-old post-coital bleeding, and she has gone to her doctor who has done her pack test, and that's come as NILM. And her post-coital bleeding is not getting cured. She goes to Mysore, where her doctor, she had delivered her mummy's place, Maika. So there the doctor, what she did was, she looked into the cervix and she put silver nitrate. So that's a chemical cautery. And she's charged. You can see these are ablative, chemical cauterization done. Now again, her post-coital bleeding is still there. Is not getting rectified. She comes back to Thane, and now this patient comes back, and now she is referred to me. Now, when she comes to me, the first thing, as I told you, is I take HPV for everyone. It goes without saying. So I had taken her HPV, I had taken her PAP, and then I've done a colposcopy there and then. Now, what did I see? I'm seeing these tissues only left out for me. Why? The history is very important. This patient has undergone chemical cauterization. So what is not burnt? Only this portion. And now when I'm trying to do a sweet scoring for her, it's a very inadequate type of colposcopy. And I'm taking a, then I could see the breaking mosaic. See over here. If you can actually really, this case teaches you a lot of things. Breaking mosaic pattern. I immediately understood this is a squamous cell carcinoma. And before even the report comes, and I was, that was a fellowship class also going on, and I told my candidates, can you actually appreciate the breaking mosaics here? And that's the reason, even after my punch biopsy, I got it as an adenocarcinoma, as a squamous cell carcinoma. So what I'm trying to get to you, take home messages are, please don't take it very, these cases, post-coital bleeding, post-menopausal bleeding, these are the high risk stratification symptoms. As told by ASCP 2019 guidelines, take this up with a pinch of salt and really do a lot of right methodology of understanding. Now, when you come to congenital TZ, now these are your miscellaneous findings. What is there? You have this acetovite, all acetovite area. Okay? So this is again a very confusing thing. So it is 1 in 40,000 cases you get a congenital TZ. And this, I was lucky in my lifetime, I've got 2. And when I was writing my first book, that is the time when I got this first congenital TZ, the first edition. And as God wishes, I got a second one during my second edition. And now I'm on my 3rd edition. Who knows, I might get a 3rd one also. So what I've seen is, the first time I was so confused, I really couldn't come to terms with my own findings, because I could see everything white going to the vagina, upper and lower vaginal wall. And I'm not understanding the fact, because none of the books have really mentioned all these things in a better fashion. So I started taking biopsies, and I took multiple biopsies, sent it to the doctor, and the doctor said, this is normal, Priya. I said, no, it's not normal. It can't be normal. And I was arguing like left, right, center, poor thing with the doctor. And he's also taking all, again, microtomes, and he's saying, no, Priya, it is normal. I couldn't come to terms with me, because it was so white and I really didn't understand. And that's the time when I did a meta-analysis survey and research in understanding congenital TZ. That is the time I understood that a congenital TZ has its own understanding. it has the whiteness going upward and downward. No, it is like the whole vagina because of the adenosis factor. Everything will look white. You don't have to take multiple biopsies. Now, in this case, I didn't take biopsy at all because the moment I put it, I knew it's a congenital TZ. So this is the congenital TZ. Now, this is a condyloma. This is a polyp, endocervical polyp. Again, stenosis out over here. Then you have over here, you can see these are the vaginal septae, 2 cervix. So you can get a number of congenital anomalies over here, double cervix and all that. Then again, my internet is a little bit giving way. Now, can you see this is a fibroid? Like yesterday also, we had this type of a case kept in that Bhopal. And they were all like worried. Oh, what did I see? Similar type, similar. I mean, whoever is now in the Bhopal team has joined this, they would really relate it. They couldn't see the upper lip and the lower lip. So what did I do? I mean, I had given it to somebody else to do this, and they were saying, Madam, kuch nahi dikh raha hai. So when I went over there, what did I do? I just widened up the cuspos, pulled it outside, so that your lips are now out. So these are the way of understanding. So what did I do in this case? You can just open it, like we all do it, right? Cervical fibroid, nikal do, and then you can do it. Not a problem. Now, again, this is a very funny case. This case is a Nebotian cyst, multiple Nebotian. This case was to be taken up for a hysterectomy, and Amir Khan saved. We have been talking a lot about Amir Khan's that Satyamev Jayate, but this case was saved because of Satyamev Jayate. She was going to get admitted next day for hysterectomy, and she apparently had to see that Amir Khan's time. She thought, I'll take a third opinion now. So she came to me the next day, and what did I do? I just took a needle cautery, marsupialated the whole thing, didn't do a biopsy because clear cut. How did I understand this case? I understood because of blood vessel pattern. So branching blood vessel patterns. I keep on telling again and again, blood vessel pattern may say you understand so many things. So this case, then after 3 months or whatever, she came for a relook colposcopy after 6 months, everything had solved very well. So no need of a hysterectomy. This is again an endometriosis, and this is herpes. So everything is seen. Now, once you have put it up as a record, you have to do scoring. Now, scoring system has got Reed scoring system, which has 4 parameters: color, acetone whiteness, vessel, and iodine staining. And when the article which I've shared with you, Varsha, is on understanding the Reed scoring vis-a-vis to sweet scoring. It was all my own study in my own cases where I tried to find what is more sensitive, what is the sensitivity factor, what is NC, NPV, PPV, and all that I found out for my own 650 cases. And I was, because see, I am an ardent fan of Reed. As an old timer, I love to teach Reed. And I love to, analyze my own cases with Reed. There are people who are with Reed nowadays also. But then here, you have to be like a Picasso, you have to have that MF Hussain type of understanding of color combinations and all that stuff. So it's a little difficult to pick up. And so, learning curve is very hard, more in Reed scoring. Whereas a sweet scoring is a very easy learning curve. Simple things are put up: acetone whiteness, margins, vessels, lesion size, iodine stain. So if you go with acetone white, you will say whether it is acetone 0 or whether it is transparent or translucent. One will have shady, milky, neither transparent nor opaque. This is distinct opaque. So this is so easy, comparing to gray white, snowy white, oyster egg white. I have not seen an oyster. How do I know the oyster egg ka kaisa hai? I have not seen a snow. How do I understand a snowy white? So you understand what I'm trying to say. This becomes very, very easy. Margins again is very simple. Diffuse has 0. If it is a sharp but jagged margins, might be a satellite, you put 1. So these are the minor. I have brought for you the differences, what I've written in that article also. Between a Swede and Reed, I will shortly show you. Then 2 is the sharp margins, uneven, raised margins. Then you come to vessels. If it is a fine regular, put 0. If it is absent, you will put 1. Now, people have asked me, why madam, absent vessels, you're putting 1, they put 1, and 0 when it is a fine vessels. You have to understand the fact that vessels are, how is a vessel seen? Because you're able to, the light is able to transcend that thing. But if there is an obscuring of light because of certain hindrances in the path of the light, you're going to not see the vessel. That's a simple, basic, fundamental understanding. So I have told you, I don't know, I don't remember, have I told you this, that HPV has different stages of infection. So that's first is the it's an infective stage when it is on the cell. Then when it actually enters the circular form of DNA, it enters into the host cytoplasm, it creates certain inflammatory reactions like interleukins and cytokines getting released. That's an inflammatory stage. And in that inflammatory stage, there will be keratin granules getting, within the cytoplasm. So you have that thickened type hyperkeratosis. This word is called hyperkeratosis in a histopath. And a parakeratosis. So if you have a hyperkeratosis and a parakeratosis in a histopath, you're bound to not see the vessel, but then that amounts for the second type of HPV infection, that is inflammatory. And then is your integrated HPV. So that's a different story altogether. But I wanted you all to make a sense of why a sweet scoring is having an absent thing onto one. And then you have a coarse mosaics and atypical vessels, you put it up as 2. Now come to lesion size, less than 5 to 15 or 2 quadrants 1, more than 15, or if it is going into the endocervix, it's 3. It's 2, sorry. And then iodine staining, brown, 0, patchy yellow or variegated is 1, and distinct yellow is 2. Total scoring of 10. How do I understand the scoring? Sweet scoring, 0 and 1 is atypical, might be an HPV infection. 2, 3, 4 amounts to SYN 1 if you have a concordance, and 5, 6, 7 is SYN 2, and 8, 9, 10 is SYN 3. Now above 5 itself, that's another article which I had written, and that had become very popular article. I had a lot of feedbacks from readers that I had written that article. That was a study which I had done. But I've understood that, which is your parameter in SWEDE or parameter in READ, above which you will treat. So that was a very important understanding. See, we are always not doing our own research, we are only going by what books are saying. But actually, if you truly become a researcher and you enjoy your whole work, sort of, I mean, at least this is what the bread and butter for me. So what I try to do is I had done this understanding by taking the histopath concordance and about what should I treat. So it was fantastically understood that if you really want to treat on a screen and treat programs and you're doing a suite, so above 6 and 7 you are bound to treat. You should treat. Now this is the middle portion where 6 and 5, 6 and all, now where you can put an IHC tumor marker to understand whether it's going to be a progressive disease or a low disease. Or whether can you wait for that to regress, because we all know the fact that SYN 2 also regresses. That's the basic understanding. Now, when you're reading it, above 4 and all, you will have to treat it, sort of thing, because READ has got 8 and SWEDE has got 10. So that's another thing. I think, Varsha, I will share with you even that article. For people who are truly interested in the subject, can go through that article and understand it well. So now when you're putting it with an acetic acid, now let's start sweeting this. Okay, I brought for you 4 cases. Let's sweet. You all also can sweet at your end and come up to the understanding of this. So if you want to take part in this like a quiz, let's start doing it. What is the first score you will put for acetone whiteness in this? Yes. Let's make it interactive rather than only me blabbering out.
Yes, please unmute most of them, those who are interested. Put on your camera.
Otherwise, it's just like sleeping, and only I'm shouting at the top of my voice with a bad voice.
Put on your cameras and your videos.
It's definitely white, it's opaque, and it has geographical margins.
So let's go to one parameter.
Right. It's opaque.
So, first is acetone whiteness.
Yeah.
What is the score will you put? 0, 1 or 2?
1.
Okay. Why 1?
It has geographical margins.
No. We are not onto margins now. We are on acetone whiteness color.
Okay. See, it's
milky white.
Milky white. Yeah, it's milky white. It has some transparent areas in it.
See, I go back to this. Understand this. You can even take a picture of it if you want to. And then you have that in front of you. So that like you can, have a correlation to what we are saying. Right. All right. So there we have, this is shady, milky, neither transparent nor opaque. So you put it as 1. For margin, you will put?
Yeah, it's 1. Sharp, and it has geographical pattern. It's like a map.
Again, and what?
Irregular.
Irregular.
Right.
So you put it up as 1. Then the next comes as?
Blood vessels.
In vessels, you see, can you see this? What is the punctations? Is this fine or coarse?
It's fine.
So what is it? You put
0.
1 plus 1 plus 0.
Yeah.
The fourth one parameter is?
Lesion size.
Quadrant.
So it's occupying more, roughly a quadrant. So it's occupying half 2 quadrants. So I think it's roughly a quadrant. Maybe 1/4 of the cervix it's occupying.
So it's occupying, say, 2 quadrants?
Yeah.
That's
not
1.
entirely 2 quadrants. Half of each quadrant.
What will you score it? And always try to score low, huh? That is also I'm telling you. That's the thumb rule.
Yeah.
Never score high. So I'll put it up as
1.
What? We put it up as 1, right?
Yeah.
1 plus 1 plus 0 plus 1. Next is?
Iodine staining.
So this is patchy.
Right.
Variegated.
Yeah.
Again 1. So it has come to total?
1, 2, 3, 4.
4.
Around 4.
4 is what? 4 is what? I just told you 4.
Sweet score. Yeah. It's a sweet score.
But what does that?
But it's
borderline. It's borderline.
Oh,
see, I told you, right? 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 4 comes in the range of Sin 1.
Sin 1. Yeah.
Or low grade. So whenever we say low grade or high grade, but I was trying to teach you all this concordance with histopath.
Okay.
So now where will you take a biopsy from?
From 6 o'clock position. 6 o'clock. 6 o'clock position.
How many are there for 6 o'clock and yahan se?
No, not that area. Near to the. I'll take 2 or 3 biopsies. I will take multiple biopsies. Just in case to be sure.
I will take a biopsy from this has been taken from this position. Okay, SCJ has to be covered.
Yeah, SCJ.
All right. So now we go to the second one. So the first case is over. Let's go to the second. Abhi dekho. For Acetone Whiteness?
Yeah, it's again same pinky white.
1.
Right.
Borders?
That again irregular.
Again sharp but irregular and geographical.
Little bit raised here.
Right.
Okay, now these are raised. So, okay, you can put this as 2 if you can. 1 bhi dalega to bhi chalega, but 2 is the, I put it up as 2.
CN2 में जाएगा शायद मैम.
तू छोड़ अभी वो CN2 पे घुसने का नहीं है करने का हिम्मत देखने का ये नहीं देखने का. So you have margins 1 plus 2 plus now blood vessel.
I think
Not seen.
Here it is not seen, but यहाँ पे जो है is a coarse mosaic.
Coarse ones, yes.
So you can put 2 or an absent vessel को 1 डाल सकते 1 or 2, but I put it up as 2, so it was 1 plus 2 plus 2. Then it says there in 3 quadrants, so 2 and iodine stain 1. So somewhere around 7 or 8 was coming as sweet. If you can put up as 1 for that absent blood vessel also is okay. It will come to 6 or 7. What is the histopath? Sin 2.
Sin 2.
Come to this.
Okay.
Hence, Acetone White.
Right.
Raised margins.
Raised margins, yes. Irregular raised margins.
Present in 2 quadrants. And patchy. Total 8.
More than 8.
Histopath. Sin 3. So Varsha is understanding. She's saying, okay. All right. So now we have over here. Good. I'm happy. So now we have over here. Let's see this.
Oh my God.
Pehla to oyster white, dense, raised.
Yes.
2 is there in all the quadrants 2.
Yeah.
Then see, pehla to Acetone Whiteness, then margins, all raised and all that. Then vessels, abnormal vessel pattern 2. Then you are putting in there in all the quadrants, so 2, and then it's mustard staining, dense white 2. So ab iska kya hai? Invasives.
Invasives.
Now we go to adenofactor. Now that also you have to keep in mind, hai na? So how do you differentiate? Columnar ka bhi whiteness hota hai because of metaplasia, right? I told you. So will I say this as a metaplasia or a lesion? Look at the acetic acid picture. Will I say this as a metaplasia? Will I say it as a lesion? That is where your understanding in colposcopy comes. Metaplasia, it is not like this. It is translucent.
It will go away, right?
This is dense. It is going
Dense.
endocervix. It is having abnormal dilated blood vessels. Look at this pattern. And then this Lugol's. So this is Sweding to 10. And what is a histopath?
Oh.
So this is a paper which I had shared with you all today.
Yeah.
And I showed you this as modified RCI and sweet scoring. What are the differences? I have brought it. So this is there with you all as a ready regular thing. And this is a study, 650 cases. I have this habit of doing my retrospective studies also. So this, I had seen a 650 cases and I found 84 lesions out of that 650 cases, which was 12.9%. And then we had this Sweding and reading and all that thing. And what I found was, it was having a concordance. My reads were having a concordance with and a correlation with the histopath in a better fashion. And so on that we do the treatment, right? And treatment was, there was less of a over treatment in here rather than in Swede. But nevertheless, had I readed it or had I Sweded it, in Sweding, I would have done a little bit of a more over treatment, doesn't matter. But nevertheless, none of the cases have gone away. But what I understood with an NPV value and PPV value and what is the threshold which I found, that the threshold which I found was 4 and above in a read, I would take it up as a concordance of having 97% of SIN2 plus on a histopath. 6 and above, I would take as a sweet scoring concordance if I have to have 94% of SIN2 plus cases. For treatment, I'm saying, because that comes in your screen and treat. And so that's what I just told you. The learning curve definitely is high in an RCI rather than in a sweet scoring. So that is there. And now this EVA tool is really making a lot of news sort of understanding becomes an easier thing. I told you, like, see, yesterday, there were 80% saying abnormal. And when I said normal and then EVA tool, AI showed a normal. So that's how you learn, because these are all the AIs have come up. These days, AIs are really making your life little comfortable, you know. So here there is a thin acetovite area. This is from EVA, which I've done. And this is, so as I told you, I have all the colposcopes in my hospital. I have Promise, I have Bose, I have EVA, I have whatever comes new in the market comes to my hospital.
Yeah,
so
we have something called a Cindy Colpo also done.
I know Cindy Colpo, that doctor had given me a call.
Anupama Bhute, yes.
Yes, Dr. Anupama gave me a call and she said, Madam, please have mine also in yours. I said, yes, I would definitely, why not? So this is what we have seen, and this, what is this AI saying that's abnormal. Now this is the procedure I don't want to repeat because it's just a procedure done by my staff nurse in the paramedic area, I mean camp area. So see here again. Now here, what is it? This case she had sent me on the cloud, and then she said, Madam, yeah, acetovite dikh raha hai. I said, Lugol's laga le. Lugol's was normal. So this is a metaplasia, immature metaplasia. And then AI said normal. Then again, I brought this case for making you all understand why do we require a tool for VIA? People have been telling, see, we have been doing a lot of camps. Many doctors from Nagpur also had come when I had done the 3,500 ka one day mein VIA. No, you all are aware of it also. And so that time I had 50 doctors and we had erected 25 OPDs and we were doing a VIA. We had screened a whole village. Now, that was a Guinness World Record camp. So there also people asked me, they had come to learn VIA rather. See, VIA is a very tricky thing, you know. VIA is the most trickiest thing than anything, I will tell you. So in this case, what am I seeing? You tell me. If I do a VIA, yahi dikh raha hai. Maine torchlight lagaya. Not seeing anything much. But when I'm putting a tool and I'm focusing it, I'm seeing the lesion above. Same is here. ये shadow में चला जा रहा है. Whereas see here it is seen. And what I saw on an AI is abnormal. So these days, WHO also is recommending AI tools. Whatever methodology you use, so many are coming up with it. Now see this case. Now again, I'll tell you certain googly cases. This is normal saline, this is green filter, this is acetic acid, and this is Lugol's. And what do you see in this case? This is a normal case, in fact. What is AI saying? No. See this case now. Here there are a lot of blood vessels seen, and look at this pattern. Look at this pattern. Now, this was similar case, like yesterday. It's a similar case like yesterday. And where 80% said this is abnormal. And I had to say, no, it is normal because of the excoriation this has gone out. So understand the history well, rather than jumping. So see, look at this.
She was a perimenopausal patient.
This is a chronic cervicitis case.
So fibrosed.
Fibrosed bhi nahi bolungi main, because of infection, the upper layer is getting excoriated, and that's the reason your Lugol's is positive. Okay. And you're not seeing any proper acetic acid. Here, all the things are looking Acetone White because of excoriation. Tissue excoriation. Upper wala layers are going away. And basically, chronic cervicitis appears so much like this. And the AI also has shown normal. Then again, look at this case. This is a case where, this is again acetic acid and Lugol's and not taken up. So these are your confusing cases where I told that this is perimenopausal, menopausal age group. This is a normal one. Whereas the candidates who had come for my EVA training classes also said, no, madam, we will take a biopsy. This is looking like thing. I said, look, AI kya bol raha hai? Normal. So you have to understand. What I'm saying is, tissue understanding is important. AI आजकल आने से क्या हो रहा है कि our understanding and learning has become normal. So I end this today's talk with this books, and these are all the reference textbook. It's all also MUH's reference textbooks. Coming with the 3rd edition now, and you should be having proper instruments. That's important. So we have designed I do my own designing, spec designings. And one of this instrument is my patent instrument. So, and this is also bag which I have developed as a portable colposcopist. Okay. So, and I have my own instrument.
There's a cryo, na? In the...
Ye dekho, ye cryo gun. Then you have this type of insulated hose, and then you have this vaginal wall retractor. Then you have different types of loops which are there. Then you see over here, these are all my designed ones. Huh? You can see this. This is that PGK instrument. This has come in our yearbook also of doctors who have designed their own instruments. So PGK automatic insulated tissue holding forceps. Then this titular I have done a spec designing with widened, the sharp border and a widened wedge. So you get a wonderful wedge. Then here in this endocervical speculum, I have elevated I have elongated the speculum blades. Then even in this ECC, endocervical curette, I have opened up that wedge more. So all these things can be done. Where here I'm showing what is the use of this lateral wall retractor. And this is, I've made it as an insulated one, with a long blades. So definitely, if you have your own, so I have developed, I've got an instrument division also. That is SVME instrument division in my healthcare. Slow and steadily, and then biomolecular lab is there in the healthcare, everything under one roof, so that we don't have to run helter-skelter. If you want to practice well, I think it's high time that we have our own done thing. So we have definitely all these training programs, and you all are welcome to come to the training programs. So thank you very much. So this is for their...
Ma'am, there are just a few questions in the chat box.
Questions. And there's a question from Sandeep Padke.
ANC patient, what surveillance is done when you find a high grade? I thought so. People should be asking this question to me. And there I get this. So what is the significance of villi but no Acetone White area, Sandeep?
Yeah, there are a few questions from Dr. Sandeep Padke.
Is there, wait, before I go down. Is there any therapeutic role of acetic acid application? So Dr. Sandeep, you have put me 3-4 questions, and again he has put me.
Yeah, the first one is satellite lesion.
You have also put me satellite lesions are due to HPV infection only. Are there any chances of development of dysplastic cells in? So I'll take you point by point. The first question which you put is satellite lesion are there. These are because of HPV infection and a low-grade HPV infection, in fact. So now, you go through this ASCP 2019 guidelines. What they are saying is this guidelines has slightly changed our understanding. They are saying if you are having any doubt, you can immediately go for taking a biopsy. So there they are giving you a preference that if you are seeing whatever acetone area, why they are saying this is they don't want to lose out any chance. They don't want to give any chance to anyone, sort of thing. But let us understand that satellite lesion because of low grade HPV, which doesn't further go into dysplastic lesion. So the chances are very less. So definitely no need to take a biopsy. But if you are having any doubt or if that satellite lesion is appearing more thing, then you can. But otherwise, I do not take it. Let's go to the other thing. ANC patient, what surveillance is done? As I told you, PAC test only if you want to do an opportunistic screening. It's not mandate. It's not mandate at all. You're seeing a cervix and cervix is appearing healthy. No, go and take a pap test. Zaruri nahi hai. But only if you feel that the cervix is really unhealthy and then you take a pap test. Why they are not saying HPV? Because again, there is a study. What they have said is the study again has come up. This is what I'm putting in my 3rd edition, which will be slowly duly released. In this, I've written a chapter of why shouldn't you do a HPV test? There is no need. In fact, this is a meta-analysis study which has shown that because your cervical tissue cells in a pregnancy is undergoing certain changes, so there are this findings which doesn't correlate to the actual thing. And that is the reason you do a pap test. It's more than enough. You do a pap test. If it is showing a high-grade lesion on a pap test, keep her under surveillance. That means what? That means you will call her up every quarterly. To tum aap karoge, you would have done a colposcopy. Colposcopy is going to be totally aberrant. Believe me, dear friends, you might get even tensed. Kya kar raha hai, kya chal raha hai? I'm not understanding what's happening around. And you might land up doing some leap or lets onto her or doing a biopsy. There's no need, in fact. A pap karte raho, sequential pap test. You do after 2 months if you want to. Keep her under guidance. Now, if God forbid that case has developed into cancer, then what will you do? Then definitely you will have to take a biopsy. Go ahead doing a biopsy. But then it should be a proper this thing, making her understand about what can go wrong while doing a biopsy. There can be high bleeding and all that. And then you go according to the stages. Then there is no other way out. You will do an MRI, shield. What can you do? Then you will have to understand the stages. And then if she's nearing her term, you can just wait till her delivery. And at that, the same go what the people do. Once they come into a maturity level, they then do that this thing also, Vardheims also, after removing the baby out. So all these things are done. But then these are very rare cases. Not every time. It's one of its kind of cases. All right. So now so I think I've answered, Sandeep, your second question. Your third question is what is the significance of villi positive, but no acetone white lesion? Again, I tell you, this is it can be an immature metaplasia. So there is not much of a significance for that. Then is there any role of therapeutic use or role of acetic acid application? No therapeutic rule. I don't know if there is, then we have to do certain study to understand whether there is, but there is no rule as such of any therapeutic. Then I am seeing what is there. Okay, all praises. Thank you very much.
Thank you so much, ma'am. That was again one more good enlightening session from you. Asha, Sangeeta hai kya? Sangeeta? Unmute kar.
Ma'am, I have a question. Ma'am, hello.
Yeah, go ahead. I'm listening.
Yeah. Unmute. Is there any scope for research? Are there any research options here in this area?
Lot. You just tell me, I'll give you research ke topics. I've been giving pan-India to many medical colleges.
तुम
बताओ तुमको क्या चाहिए?
Medical college.
I would love to.
Rujuta is working in a medical college and she is regularly doing colposcopy. So probably her interest.
Yeah.
So you talk to
Medical
me,
college.
Rituja, I'll give you plenty of, I have been giving to N number of medical colleges.
Yes, ma'am. Yes, ma'am. Definitely, I'll get.
I will give you thesis topics also. Don't worry.
Yes, ma'am. Yes, ma'am.
After
Definitely.
10 years, ki Rujuta will go to madam.
Yes.
We'll take Swarna along also.
Yeah. Definitely, ma'am.
Chalo then. Okay.
It was a very passionate teaching, ma'am, and I really appreciate your teaching and your.
Madam is the first doctor to support Amir Khan.
अरे नहीं रे, मैं वैसे सब नहीं बोल रही है. Don't take it otherwise. ये तो ये आ जाएगा कि मैडम इज प्रोपोनेंट ऑफ अमेरिका.
नहीं ऐसा नहीं है, but then she has done the right thing ना. She has avoided the hysterectomy और क्या? नहीं समझता है लोगों को. Probably if she's got a right guidance, so that woman's uterus has been saved.
So Dr. Vandana wants to come to learn. Yes, thank you very much for all your appreciations, which I'm seeing on the chat box. You're all welcome to come to this training programs. We have this. Are you aware that I also run a online training program?
No, ma'am.
I'll be sharing you the calendar. Varsha.
Yes, ma'am.
You can
love
share
to have
to
that
your group.
online.
Huh?
Okay.
So I have brought excellent, and these are the type of hybrid type of teaching, you know, where 10 videos have been come, and then even I come live like this interactive session.
Okay.
So that also, I will be sharing the calendar with you.
Yes, ma'am. Thank you, ma'am.
All right.
सोमवार के फिर से राह
See you
देखेंगे.
next Monday.
Next Monday. Thank you. Bye.
Bye.
Bye. Thank you.